Good afternoon, everyone. Thanks for joining our session today on breaking barriers of artificial intelligence and machine learning in digital health. I'm thrilled to be serving as the moderator for our panel here today. That includes Dr. Bradley Erickson from the Mayo Clinic and Elad, the CEO of AI Doc. So the scope of our discussion today is very timely. The use of artificial intelligence and machine learning applications in healthcare has been marked by excitement and unlimited potential. The industry is supposed to have an expected growth to reach almost a 45 billion by 2020 and has only been accelerated through the COVID-19 pandemic. The interesting conjecture here is that healthcare organizations and execs seem to be prioritizing AI. Almost 33% of healthcare executives suggested that AI have a strategy for AI in place, and another 15% are planning or creating one, according to an annual Optum survey on AI in healthcare. 59% of them are anticipating AI delivering tangible cost savings within 3 years, a 90% increase in their opinion since 2018. While the benefits of AI are clear, most healthcare industry still sees it behind the curve, as only 20% are in the late stages of deployment. So we are going to try to uncover this a little further and understand what the future potential holds and how we are going to accelerate these efforts. With that, welcome Dr. Bradley Erickson and Elad. Really excited to have you here. Just to kick us off here and get the conversation going, let's go around the room and introduce ourselves and help the audience understand why have you engaged in AI in healthcare and what's your experience in this arena.
So I'll start, I guess. So I'm Brad Erickson. I'm a neuroradiologist here at Mayo Clinic. I also have a PhD in biophysics, and that PhD was on image processing. And at the time, back in the 80s, AI was really not very effective. So I went into the film conversion to PACS and did some interesting research. But then about 10 years ago, started to get back into the world of machine learning. And obviously that was great timing because things have just taken off since that time. I run a lab now of about 20 postdocs. I also am involved with a spin out of Mayo that focuses on how to help apply these technologies in the practice. So it's a platform technology using intelligent process automation that lets us string all these tools together and make sure that each AI tool has the right technology.
Yeah, and I'd like to connect to the challenge Dr. Erickson is mentioning, right? I think that the big challenge of making AI work in practice, I think, is where a lot of AI technology is today. And that's I would say, my connection to it. So personally, if you hear from the accent, I come from an Israeli background. I've headed the artificial intelligence, the Israeli Air Force for a few years. And while doing that, I learned that you can have the best algorithms in the world, but making it actually work in production is a massive lift. I would say it's even, it's 80% of the work in terms of making AI work. And with that, with that experience, I co-founded ADOC about 5 years ago, being really passionate about, trying to make AI work in the healthcare space. I say that we're fortunate today to be one of the leading players in AI that is actually running, raised over $130 million, 250 employees, serving over 500, 600 medical centers, and with clinically operational AI that can generate insights and action. Maybe I'll give an example just to get a sense of what it is that we do. Every imaging exam in the facility, let's say CT, MRI, X-ray, is sent to the ADOC engine, which then searches for certain critical findings, let's say brain bleed or stroke or pulmonary embolism. And once identified, we help triage and prioritize those patients, as well as notify the clinical specialists. So let's say you have a busy ED with maybe 50 patients coming in a busy night. Patient number 50 with an actual brain bleed may wait for hours in a busy ED environment. With our solutions, those patients can be detected by the AI, shot to the top of the list, and make sure you get and treat those patients right away. And Tarun, I may just finish off by connecting to the first point you mentioned. I am just so excited about this time for AI, to be honest. For my company, I will say we've been deployed at less than a handful of sites 2.5 years ago, right? Today, we're over 600 medical centers. I think the pace of innovation and adoption of these technologies in healthcare are probably unheard of, and that's a first. And this is why I think it's so important to think about how to do this change management effectively. It is going to be transformational to some extent, and we need to be both mindful of those effects, as well as keep thinking about how we keep pushing the envelope with this useful technology. Tarun, you're muted.
Awesome. Thank you so much. So just to build on that, the change management that's necessary to effectively operationalize this technology, Dr. Brad Erickson, if you don't mind, can you just build on that? I know Mayo has been really building a lot of AI algorithms for a substantial period of time. Could you just walk us through a use case where Mayo has been able to successfully operationalize this in practice, and what were some of the challenges you've experienced?
Sure. There are a few tools that have been developed in my lab and also like in cardiology. And, the part of the challenge starts with how you built the tool. So I was kind of giggling internally when Elad said it's 80% of the effort to deploy it. He's right. But another 80% of it is to build the tool and do all the data cleaning. And a problem is that as we do the data cleaning in order to train the algorithm, that's not real world data anymore. And so that's why the other 80% of the problem is that how do you put it into clinical practice? So as an example, we trained one of the algorithms we have for doing body composition on CT scans. But there's been tremendous evolution in the technology of CT scanning over the time period that we had used. Furthermore, we have different vendors, and like many hospitals, we have one preferred vendor for imaging. And so the minority of scans that were not from that vendor didn't perform as well. And then there are other factors like, did they use contrast or not? And then if you're going to start to use the data, how do you use that data effectively in a given patient? And an example, now I'll point to cardiology. When you start to build predictives and say this patient has a 10% risk of low output failure, well, what do you do with that? What's the number where you then go on to do more invasive imaging? And I think that that's a challenge that particularly people who are not cardiologists struggle with. And similarly for body composition, okay, I can tell you what the amount of muscle is. Is that normal, abnormal? Surgeons particularly find it valuable because they've used it enough to say this person, has enough muscle, they're robust, I can do a major surgery. But some of the, correction factors like gender, like race, are still not well understood. And so for those that are real close to the dividing boundary of, yeah, this is okay and this is not, that's a real challenge. And I think that that's still a piece that we need to understand for probably most AI tools.
Yeah. Yeah, that's very fascinating, right? I think having a process engineering background, the change management starts from when you actually start building the tool, not after it's built and you're now trying to figure out what's the best way to operationalize it, especially because some of these data sets are not perfect, right? There's the whole diversity component that goes into it, and AI are learning algorithms. So Elad, do you want to build on that a little bit? Sounds like you have a platform that's really able to provide these solutions to caregivers. Being a startup, how do you really tackle that challenge of engaging the providers right at the inception of even a conceptual AI algorithm?
Yeah, I think that's a really good question. And to be honest, when we think about AI, it's you have to engage with clinicians across the whole spectrum of making a solution. And internally in the company, we kind of speak in three layers. There is the algorithmic layer, which is, well, you just want to make sure that you build something that works. There is the product layer, which is how do you bake it into a workflow and make it something that is actually usable. And there is the third layer, which is the solution layer. And what that means for us is that we want to target specific pain points and understand what is the clinical value. So to give an example, if I'm developing a great brain bleed algorithms, so what, right? Like, what am I going to do with that? Is this, in order to enable faster treatment, in order to help avoid misses, in order to prioritize, like what it is that you actually do and how do you build that to solve a pain point? And I think that the engagement with the provider should be across all of those layers, right? So on the data layer, definitely you need to understand the different populations. And sometimes, we're talking about diversity, which I think is incredibly important. And on top of that, you have different settings, right? So even prevalence of disease, which immediately should impact algorithms, are different between outpatient setting and an inpatient or an ED environment, right? All of those are completely different. So understanding the data variability is important, and we typically do a ton of data research just to get us started on that spectrum, understanding the different populations, how it shifts, like making sure we understand the main variability factors. On the product side, so again, workflow is key, I think, and understanding the different workflows and how to integrate and building that together with the provider, that's also very important. And the third layer, which I think is, to be honest, I think is somewhat sometimes forgotten by some AI players, right? It's not about building the best algorithm. It's about making the biggest impact for care, right? And that you must have the deep clinical partner to achieve, because you can't, that's something that us as industry, we can bring to the table. Like what Mayo Clinic, I think, oftentimes can do is really innovate in how are they using the algorithms to the best extent. So I think engaging with providers is crucial across all of those different elements, if that makes sense.
Perfect. Yeah, that makes total sense. And I think that's where it's a perfect partnership between provider organizations and some of those technology data scientist component of the spectrum. So just to move us to a different level of this conversation, right? When we kicked off this session, I talked about how only 20% are probably at the point where they're ready to be scaled, integrated within the clinical practice. And there's this old philosophy, right? It's almost like bench to bedside, even in clinical research. Within the lab, it takes almost about 20 years. But to some extent, we can argue that was challenged with the COVID-19 vaccine. What does that look like from once the AI algorithm is providing the level of precision necessary to really implementing it in the practice? What does that time scale look like? Maybe let's start to unwind some of the challenges you run into in really making it scalable beyond change management, right? There's policy that plays into it. There is the legal complications that are associated with it. So if you want to kind of, from your experience, elaborate a little more on that, we'll start with you, Elad.
Yeah, so I would differentiate the two levels, right? So the first phase is developing a use case. And for example, now we're talking like a lot of our solutions are across AI triage. So developing that use case is typically like the first time you're doing that. That's pretty long. I would say it takes about 1.5 years because you need to build, even like you need to build with the FDA. How do you regulate something like that? How do you get this? And we were, the first with our type of solutions. So that took a while for the first solution. But then it scales fairly easily because once you identify the use case, then you can scale across multiple diseases, right? So we're doing triage. Okay, so we start with brain bleeds, and now we want to do pulmonary embolism and spine fractures and whatever. And that is actually much more efficient these days. And we're talking about, for us, from concept to FDA clearance is about a year, I would say. And we can do multiple in parallel. So it takes, I would say, about 6 months to develop and validate, and then another 6 months to go through FDA clearance and kind of build a product around it. So hopefully that answered our experience. I think, and maybe I'll add one more note. I think that's what's exciting about AI is the scalability. It's not just that you can create something that is more accurate today. It's also that you build an engine that you can easily scale. You feed it data across a specific use case, and you can easily scale it across multiple pathologies. And I think it's a massive difference than you had image processing even 10 years ago, where you had to build the features and kind of build a unique algorithm for each disease. That takes a lot of time and effort and really makes it hard to scale. With AI, you basically build this engine, then you just feed data, get algorithms. And even for us, as an example, we scaled from 1 to 12 solutions at this point in the span of about 2.5 years. So it's really fast growth in terms of number of solutions that are available. So I think that it's a combination of shortening of the length as well as the ability to parallelize those, which makes the innovation in this space more accelerated.
Awesome. So Elad, just to build on that, you said that you've been able to scale almost about 12 algorithms, right? And I'm understanding it's from really the concept to FDA clearance to get it into the market. What are the key characteristics of the most successful algorithms out there, right? I can imagine some of them break into the market sooner than others. For a variety of reasons, could you reflect a little more on what are some of those themes you're observing already?
Yeah, I think that two things. So the first is not on the AI side, is actually on the ROI side. So the more direct the value is, the easier it is to sell it. And in AI, you're building these new clinical pathways, and oftentimes there is value, but the question is how easy it is to prove that value, right? And how much of it is education, or they're already aware that there is a pain point. So those that have fairly direct and clear ROI, like acute product, let's say stroke, pulmonary embolism, those typically go faster because the market already understands that there is the pain point in those fields that AI can help solve. And the second thing, which is also interesting, I think prevalence of disease also plays into that. It's kind of a related point, but in terms of user engagement, it's hard to really get the users hooked for something that appears, once a month. Even though there may be massive value in that, don't get me wrong, but getting people kind of engaged with a new technology, it's more difficult. So getting something that is actually prevalent enough, also we find that helps adoption.
Dr. Erickson, your perspective on that, having run a massive research program and then also supporting some of the platform work at Mayo Clinic, what's your take on this? How do you really differentiate between what is a great research algorithm, which has good research potential, but not the lowest hanging fruit to implement into practice because it's going to be a challenge? So what's your take on that?
So I tend to partition the AI problems into several spaces. I think that there are some applications that are sort of like screening or triage, like what Elad mentioned, where you're looking for a finding, and making sure that you get that right is a critical thing. The advantage for that is that the data collection is relatively straightforward to do, the clinical implementation is relatively straightforward to do, and the clinical application, what does the doctor need to do about it, is straightforward. So I think that's a great place to start. I think another area that is pretty straightforward is what we call segmentation, which is essentially defining the contours of things that you see in the image, right? So this is the liver, these are the kidneys, these are the heart, or whatever there's a lot of quantitative work that's done in radiology. And I think that that's another low-hanging fruit area. It's something that most people really don't find intellectually stimulating to do, but it's something that's really important to do. It's important because a lot of diseases are essentially diagnosed based on measurements. Cardiac output, right? If you have low cardiac output, that puts you into a certain category of diseases. Or if your total heart volume is above X, that puts you into certain diseases. We've done a lot of work with a disease called polycystic kidney disease, where you do the height adjusted total kidney volume. And depending on that number, that tells you you should be treated with drug X or not. So that's kind of another, I think, low-hanging fruit area. One that's, I think, going to be the kind of the next generation is what's called multimodal AI. And this is where you start to combine multiple types of information together. And these are problems that today humans still beat AI. One example problem that we work on is trying to figure out progression of brain tumors. So it used to be that you would just measure the size of the tumor, and if it's getting bigger, that's getting worse. Well, with some of the new agents, that actually is no longer true, that you have these paradoxical responses where, in fact, you can get more enhancement, more mass effect, and it turns out that those patients actually do the best. But it happens within a certain time range, in a certain part of the treatment scale, and you need to know what's happening with the drug doses. So you can't just send the MR scan and have it figure that out, we think, or at least, so far nobody's been able to show that. But we think that by adding in information about showing where the treatment field was, what the timing of the radiation was, what their dose of temozolomide is, and whether it's going up or down, and steroids, we probably can get, and then also the MGMT marker, right? So now you need a much more sophisticated platform to pull all that information together. And that's one of the unique challenges. And that's where I think this platform technology I mentioned is going to be kind of the next thing that's required. We do all that integration of information today with SQL for building the training data set. But when you go to implement it into clinical practice, SQL is not going to be the tool that you're going to use. You're going to need a different type of technology. And so I think that's how I tend to categorize things is, we've got some of the straightforward ones where it's just the images, just measure the size of something. But now as you start to get more like what human decision making is, where you integrate multiple types of information, that's going to be a lot more challenging. The FDA is going to have to try to figure out how do I count not only the image data, but also this other types of information that comes in, and are those units all identical? I'm struck by one of the large EMR vendors has a tool for identifying sepsis, and they say, yeah, we've trained it on data from around the world, but you need to retrain it on your local hospital data, and you got to retrain it, right? So there are problems of drift. There are problems with how data is collected. And, images tend to be fairly objective, but you would think a drug dose or that would be objective, or a temperature measurement would be objective. But there are clear, subtle elements of this that we don't understand or that we're not recognizing that we need to be very mindful of as we start to put these tools into practice.
That's awesome. I think as I listen to your responses, there are like three key themes that almost surface, right? It's like, how do we prove the return on investment on some of these AI algorithms? What's the scalability of these AI algorithms, right? To your point about, do they need to be customized every time? And then what's the validity of the model at that point, right? And then the third thing I'm hearing is that whole risk of false positives and false negatives, and how is that going to play into really execution of these algorithms, where if it's just, from an operational excellence standpoint, if it's just triaging patients to the right provider, probably more acceptance compared to a brain tumor decision that's completely being driven by an AI algorithm. That's awesome. So just to build on that a little further, I think we have focused more around adoption by clinicians and caregivers, right? But healthcare environment is really complex, especially in the United States, right? Where consumers don't necessarily pay for it, and there are a whole bunch of stakeholders we need to work with when it comes to payers, when it comes to pharmacy. There is a wealth of stakeholders that need to really buy into some of this. So tell me more about what you're seeing, Elad, with your products or Dr. Erickson within Mayo Clinic, right? Like, how is this value proposition really being brought to the forefront, not just for adoption by clinicians, but the broader society, including the patients? I'll start.
All right, Tarun,
Yeah. If you want to go, we'll start with you.
I'm
Go ahead.
okay. Yes. So I think that's a really, really good question, and our perspective on this is that the value chain is really broken down and siloed oftentimes, and it's very difficult. I'll give just an example to kind of get the sense. Let's say I can triage. I can reduce time to treatment for stroke patients. Okay, let's say that that's what my AI does. Well, who's gonna pay for this, right? So on the one hand, you're gonna start with the clinicians. Why would they care about this? Well, they could care maybe because it's quality of life. They have better workflow, right? But they don't get immediate ROI. So, but then you go to the health systems. Well, now they're talking about better outcomes for their patients, more interventions. Okay, now you're getting some ROI. But then you're getting to the payer. The payer look at this completely different. Can you reduce the total claims cost, et cetera, et cetera, et cetera? And we have all these, unique models where today health systems, some have value-based arms, so they somewhat risk-based, but somewhat not. So agree with you that the value chain and the complexity are definitely barriers to adoption. And I think the solution today is at least that you need to carefully craft the value to each of the different stakeholders. So I have literally 10 different decks depending on who I speak with. Not because the solution is different, the solution is the same, but each time I need to focus on a different angle. And in terms of clinical research, by the way, I need to have we need to do dozens and dozens of clinical trials, each to validate a different point in the value chain, the accuracy on the one hand, and then the impact on turnaround time, and then the impact on stay, and then the impact on total claims. And you need to have all of those different pieces in mind in order to really engage the market. And this is why I think that AI adoption is really dependent on both industry and the clinical ecosystem getting this right and being able to translate these cool algorithms into kind of the understanding of the full value chain. And you've mentioned this at the beginning, the combination of the clinical providers with industry. I think that's incredibly important because this is what clinicians can do well. They can translate technology and innovation into real world value and understand how health should be delivered 10 15 years from now. So no easy answers here, but I will say that from our experience it must cater to all of those different points. The one that is I think relatively missing today and I think should be changed is the patient. I think right now the decision making does not involve the patient that much. It's provider, payer, administrator, physician, but I think the patient should have more exposure to what AI does, and I think it will shift over the next 3 to 5 years.
Yeah, I don't disagree with anything that's said there. I think that the ability to measure the impact of AI is a challenge, right? I mean, if you're really going to do it in a truly scientific fashion, it means you got to have something like a fake AI report. And, that's going to have some ethical issues. But, having said that, there was one very nice study done, just published maybe a week or two ago out of the UK, looking at the value of large vessel obstructions. So, basically the big vessels inside your head that cause a stroke. And ultimately what they found is that across the UK, LVO detection AI software probably would save something like $11 million. Now, there are a lot of assumptions built into that. How often do radiologists miss it? How often will the AI pick those up? But also all the cost of care, the value of quality adjusted life years, and so on. Now, in the end, I was actually kind of surprised. $11 million across the whole UK is not that much. On the other hand, if I was one of those patients who was positively affected, I know which one I'm picking, right? So, to bring it back to Elad's point about the patients, we can't have everything be focused on dollars. I think, though, that third-party payer engagement is valuable because that is a metric that we can all understand, right? Even if it would have been a negative $11 million in that study, would that have said, oh, we should never use AI? Well, probably not, right? There are a lot of human factors that come into it. There are a lot of assumptions that come into it. There's the constantly marching tide of technology. It's getting better. Oh, but by the way, the cost of drugs is going up, so that moves it negative again. It's an extremely complex problem. That's a long-winded way of saying we clinicians generally have a sense of this is the right thing to do. And, again, talking with patients, some patients love AI technology, some don't trust it. And you have to kind of get a sense of what the right thing is to do in these particular situations.
Yeah, that's awesome, right? I think depends on how educated the patient is to be able to embrace some of this technology as well. So, classic use cases when it comes to health platforms, right? Not healthcare, not when you're sick, but more of that preventative services. I think most patients, at least I am very open to embracing it and using it to really drive my behavior on a day-to-day basis. But as you rightly pointed out, the other challenge with that is that really going to lead to overutilization of healthcare? And how do we really tackle that challenge? Perfect. So, I think as we are sort of coming to the end of our discussion here, I want to get your thoughts on, in a perfect world, right? Where do you see this going? What do next 5 years look like as far as AI basically supporting healthcare services, or is it really going to, what is it going to look like in 10 years? And what is your ideal vision for what should be the significance of AI in the healthcare ecosystem? We'll start with you this time, Dr. Erickson.
Okay, well, so I'm going to start by bending the definition of AI a little bit. The original AI product in medicine was for figuring out what a blood infection was and what the right antibiotic should be. Simple form of rules. That's what this intelligent process automation is saying, when you see this, do that. That is something that I think actually could and should revolutionize medicine in this short 5-year window. There are so many challenges of handoffs where, oh, I thought you did this. Or, no, my way of doing this is better than your way, right? If we had one agreed upon process, and if we had this IPA technology to help us make sure that every patient was taken care of in a right way, you can put timers on the step saying, oh, you forgot about Mrs. Jones in room 233, and escalate that appropriately. And then you start to weave in some of these AI technologies as well. I think that actually has a lot more potential because we humans that are in the healthcare system, we make mistakes. And, having a process system that would keep us within the guardrails would be extremely valuable. More generally, I do think multimodal AI is going to start to become the bigger thing. I think that's what we need to do to really solve more complex medical problems. 5 years, it's probably pushing it. There are just a lot of things to be done with that, and that may be starting to come on, say, in year 4 or so. But I think in the short term, just getting the processes right and using this form of AI to help us do our processes correctly and efficiently, that's probably the bigger impact.
Yeah, I totally agree with Dr. Erickson. When I speak with hospital CEOs, I like to ask, what's the hospital of the future as well? And many of them say, the first thing that comes to mind is data-driven data-driven hospitals, right? And what does that mean? It means that instead of having these silos of information all across the enterprise, you have something that sits on top of all of the data. But having just warehousing all the data isn't enough. You have this something that makes intelligent decisions and drives action based on this data. And I think that's the role of AI, a sort of operating system that is much more data-driven, much more intelligent, much more consistent, much more personalized. You get all what you want by having this. Dr. Erickson mentioned intelligent process automation. I think that's a great phrase, but basically an intelligent way to drive workflow. And I think this is where clinical AI will be, I think even the 5 years range, I think we'll see significant changes in how people operate. Already today, we see AI shifting from augmentation alone to literally driving the workflow for some use cases. And I think we'll see it evolving more and more. And the beautiful thing that will happen also relates to the multimodal point. I think that we'll start seeing the silos break, right? So now we have, decision making based on radiology or based on lab data or whatever. And it's already happening that the walls are breaking down and data is becoming more clustered. So you're making intelligent decision based not just on imaging, but on, like physicians, on imaging and EHR data and labs and vitals and all of that. And there are already use cases today that utilize all of this information for the intelligent decision making. But I think 10 years from now, it's just going to be so ubiquitous that you'll see this will be, I imagine this will be the main way to drive workflow in the majority of use cases.
That's awesome. Really great thoughts there. I really like the terms intelligent process automation and Elad, what you said around not just augment, but drive workflows, right? I think that's where the future is at a very high level. There's a lot to be uncovered around what it means and how we are going to get there. But that's what I think really makes it more exciting. And there's so much opportunity for everybody to really define that future. So I just want to take a few minutes to really summarize some key takeaways for our audience, right? And please feel free to add to this list as I do that here. So clearly, I think we all believe that there is a future for AI. It's already proving its potential. And there is a need for us to really move to data-driven hospitalization to eliminate those silos. I think as we are trying to implement these AI algorithms in practice, in clinical practice, it's going to be important for us to give diligent thought to what the return on investment is, what the false positive and negative consequences are going to be, and then what gap is it really going to fill within the workflow, all with the intent of keeping it centered towards patient outcomes, right? Patient is at the center and core of this. The other things are really going to align appropriately. And then the last thing I do want to focus on that we talked a lot about is that when people ask what is the potential AI has, I think it's the standardization of care. You mentioned this a lot around care pathways, right? It's that standardization of care pathways universally. There are a lot of gaps there. There have been multiple attempts at really driving that value, but there's significant opportunity for us to get there. And importantly also, right, like I think given the availability of data and if the change management challenge gets tackled, the research to really utilization in practice, that timeline is really not as elongated. It's really very streamlined. There's still opportunity there, but it's not as bad as it used to be for bench to bedside. So again, great discussion. Thanks for being here. I'm sure our audience have taken away a lot of key information from this. With that, thank you again.